I'm Lana. I'm very happy to be here. I'll do a brief visual description. I'm a white woman. I have straight gray hair down to the length of my shoulders. I'm wearing eyeglasses with a brown frame and a colorful blouse. I'm behind a podium, and behind me there is a big screen. So I'm going to talk about the work I've done in the past year, looking at ethical implications of COVID-19 vaccination policies for women, girls, and other pregnant people in the region of the Americas. And just to very briefly give a very, very brief background so we can focus a little bit more on the analysis, just to say that the region of the Americas is the epicenter of the COVID-19 pandemic, worst outcome in terms of number of deaths due to COVID. Also, several Latin American and Caribbean countries have disproportionately high maternal mortality related to COVID, and that those who are pregnant are at higher risk of severe COVID-19 and death. And vaccines are safe and effective means of protection. The analysis was looking at 45 national policies regarding COVID-19 vaccinations during pregnancy in select countries of the region of the Americas. And here, although the division of the countries coincide geographically, I just want to clarify that the global north and global south concept is in reference also, it's not only limited to geographical locations, but is also in reference to entire structures of power and politics through which significant social and health inequalities are maintained. So the 5 global south countries in Latin America that I looked at were Argentina, Brazil, Colombia, Mexico, and Peru, and in parentheses is the number of national policies that I looked at, and the global north countries were Canada and the United States. So the analysis was based on reproductive justice and feminist bioethics framework. That means that I paid close attention to how gender, racial, and social and economic inequities were considered in these policies, as well as to structures of political regimes of power and political regimes of power, and focus on gender equity as, and here gender is understood as a central social construct that can lead to inequities in access of health resources, and the health resources that I'm talking about here is vaccination as a means of protection against a lethal emerging disease. So here is a table that summarize the latest findings of these policies. This table can be a little deceiving because these policies, as you can see, they vary greatly through amongst these countries, but they're also varied a lot through time. This is not it didn't start this way. So many countries that now have no requirement for medical approval or medical order, initially they might have had that. But what I want to point out is that there were restrictions based on gestational age limit, and that varied even in the countries that had them. They are not the same. And also there were written informed consent requirement, and I have to say here that all the countries that have informed consent requirement, they had for the general population also, but I think what's interesting to look at is that not every country had a written informed consent requirement, and also to put in context of what it means to have a written informed consent in the global south context. And so there were also requirements for medical order or medical approval or medical opinion, and age requirements that also changed a lot. And I think the important thing to note here is that inclusion of younger or of people who consider minors that were pregnant usually came later than the initial policy regarding vaccination of pregnant women. And they also have implications of requiring of a signed informed consent of the legal guardian, and some changed according to as the manufacturer of these the vaccines changed the age requirement. But as I think we've heard several times already today, throughout the presentations here, context is very important, and there have been a lot of already studies that talk about maternal mortality in these countries, but here I'm putting this latest one that is has just been published in the Lancet. That is a regional report, so I think it will give us a broader perspective that in low and middle income countries, pregnant women with COVID have 8 times greater risk of dying compared to those in high income countries. And also, it's not every woman, right? So the paper described that almost the totality of these women, 92.2% were non-white ethnicity. That includes Afro, Black, Indigenous, Mestiza, and others. So I just want to point out, when I bring this table with the maternal mortality related to COVID from the PAHO report from December of last year, and we can see also a huge, you can't see my cursor, but a huge disparity between the global north countries and the global south countries, which also shows that, as with other causes of maternal mortality, they are vastly, over 90% of causes of maternal mortality are preventable. So it seems that is with COVID. And when we look at these very high numbers, so if we compare Brazil, that has the highest rate, with Canada that has the lowest, that's almost a 70-fold higher, or more than 70-fold. And when we're looking at these numbers in the global south, we are talking about these Afro-Black, Indigenous, Mestizas, and other women. So what I found in this analysis is that policies can be moral technologies and can lead to exclusion through knowledge production and knowledge selection. So knowledge production, and in this case I mean about the non-production, and this has been described by the PREVENT working group that works on pregnancy research ethics in epidemics, and they talk about a cycle of exclusion where pregnant women are excluded from studies, so there's no data about them, so they're excluded from the delivery, and here they were excluded from the policy, so they were either totally raised by, and every policy noted lack of data to justify the delays of inclusion or the non-inclusion of pregnant women in their national plans. And this is also related to the next mechanism of exclusion of knowledge selection, because we already had a good amount of data about the necessity and the need of inclusion of pregnant women in clinical trials and research, about the effects of disease outbreaks in women's health, also about the effects of other coronaviruses and respiratory virus like H1N1 in pregnancy well-being, and the safety of vaccines in pregnancy. Yet all this knowledge was selected out, and a different set of knowledge was selected in, making, even when pregnant women were present in these policies, they had a restricted presence where other factors took precedent, like such as gestational age and medical opinion. So these are effective mechanisms of exclusions because they confirm morally based understanding of woman, pregnancy, and motherhood. They allow for and officialize a dispute of rights between the pregnant woman and the pregnancy or the fetus. And these policies materialize the subjugation of the woman over the reproductive potential, leading to a de facto effacement of women's autonomy, agency, and authority over their bodies, ultimately impeding them, pregnant women, the option to protect themselves. So this matters because if in the global north, severe COVID during pregnancy was found to be almost exclusive and limited to the unvaccinated, in the global south, where lack of health access during pandemic has been noted as an important contributor on maternal health outcome, vaccination would have been one of the few chances of survival, and in particularly for racialized women in context of global south who historically suffer from oppressive structures. And it deviates our attention from relevant questions centered on pregnant women's health and rights, and limits our imagination regarding how to design and execute inclusive and gender equitable public health policies. And that's it. Thank you.